So to continue the surgical management of retinitis, I'll just add in a few general takeaway points. So one, RD is a common occurrence after retinitis. So whenever you have a patient of retinitis who suddenly develops decrease of vision, please look at them carefully. So what happens in these patients is there is peripheral retina is plastered because it's heel retinitis. So the central retina would not be very bullous. So it's a very shallow detachment usually, and you may miss initially. So do not miss that. Second issue is that there are lots of, as Dr. Rohan showed, there are lots of holes in the atrophic necrotic retina. Now, once they do happen, what happens, overlying vitreous becomes membranous and it is very tenaciously attached to the retina. So once that happens, it can lead to rhegmatogenous RD, tractional RD, or even a combined retinal detachment. Uh, Progressive outer retinal necrosis fortunately is not very common, but remember, RD is more common in ARN followed by CMV and least common in toxoplasma, and once it happens it causes severe vision loss. So before we go to surgery, remember there are some preoperative consideration whether retinitis is active or not. Now if retinitis is active, please do continue your antivirals. So that is first thing. Do not forget about immunosuppression. So patient comes with HIV, with CMV-RD, please start ART before you start the surgery. See that patient is comprehensively taken care of, screen the partner and the patient for other STDs. And once you are doing surgery, please, we have to be careful of our safety also. So please use all universal precautions with proper waste disposable. And preferably in our setup, we like to do these cases at the last case so that the OT can be cleaned after that. Now, some intraoperative considerations are that there is thin friable atrophic retina in the healed area. So, which may appear scarred, but please do not pull on to that. It can cause breaks in the attached healed retina. Now, that will be a very difficult thing to tackle because there is already scarring there. Once there is break, it starts to get lift up. It would be difficult to induce a retinopexy. Second is, as Dr. Rohan showed, the vitreous tends to be membranous with multiple layers. So that is okay, we can take care of that. We are used to handling multiple layers of vitreous, not in myopia and diabetes. But additional problem here is that it is very adherent, and where it is adherent, it is specially adherent at the edge of the healed and normal retina. Now that is our watershed zone. We don't want to do induced traction anterior to that, but at the same time the maximum adherence is at the point, at that particular point. So we have to be very careful about this particular fact. So I would like to put it in this way. In fact, this junction of healthy and necrotic retina is new ora serrata, but it is a weak one. So we take our ora serrata as the strongest attachment, but remember here it is a weak ora. Lastly, because there has been previous inflammation, there is poor blood ocular barrier, and these eyes are very prone to PVR even with mildest of uh, intraocular manipulations. So you can do anything 27 to 25 gauge. We prefer 25 gauge because there are many tough membranes which may not be amenable to 27 gauge. As Dr. Rohan mentioned, thorough vitrectomy is required, but if there is peripheral lot of healed retina, you may not need to do anything to the lens. But if there is involvement of the peripheral retina which is there, you need to do base shave, then you will need to sacrifice the lens. If there is active retinitis, please avoid triamcinolone, as residual triamcinolone may affect the disease course. As I mentioned, there's no traction should be there at the edge of healed and necrotic retina. As Dr. Rohan mentioned, a broad laser has to be there. 2 rows of retinal laser we normally do in a break do not suffice here. So you need to give 4 to 5 layers as we give in a case of GRT. And even if even in cleanest of the cases where you think you can get away easily, please do not leave the eye under gas because these eyes are very prone to PVR. So So oil is the tamponade of choice in most of these cases. So I'll just show you one case quickly. So this is a patient with CMV retinitis with retinal detachment. As Dr. Rohan showed, there is vitreous which is quite membranous, but in this patient I was able to induce PVD. So you can see the vitreous is quite hazy, and that is a boon in a way. You do not need triamcinolone, and it becomes membranous. As you can see, there are some membrane. So once you do the core vitrectomy, so the second challenge comes is that these eyes tend to have a very gel like vitreous which is there. So if you catch these cases earlier, the membranes are not yet found, but there is jelly like vitreous, and you can see there are multiple breaks here. You need to get all the vitreous of these places, and since the underlying retina is very necrotic and thinned out, you need to be very gentle before you can pull these cases. So you can see this is a healthy retina, necrotic retina. There are membranes. You just need to be very carefully go near the surface of the retina and tease off these membrane and cut off. So there are large breaks here in the superior retina, fortunately for me in this particular patient. So you can use these holes, necrotic holes, for fluid air exchange, and once you have gone through that, you need to apply wide laser 4 to 5 layers all along 360-degree. Again, this is not a choice here. You need to laser in 360-degree. You can see here I am giving 4 to 5 rows of laser, and that would be continued all around. Now in this particular patient there was a challenge because the retinitis in the infratemporal part was just approaching the arcade, but still I was able to you can see here it's reaching up till the arcade. So what I am doing is laser partly in the necrotic retina, but you need to extend your laser into the healthy retina so that it can hold on. So we laser it all around and put oil. So this is the patient I showed you earlier in my presentation. So this is how he had a RD, and after the retinal detachment surgery, you can see it has been lasered 4 to 5 rows of laser, and macula is fortunately preserved in this particular patient. Thank you very much.
Thank you, Dr. Vinod. Any questions? Okay, thank you so much for attending this instruction course. I hope you gained something from it. Thank you. Thank you. Yeah. Sorry, there is one question. Yeah, so encerclage probably again has become a surgeon's preference. So if you are believe in encerclage, you will put an encerclage. If you don't believe in encerclage, you will avoid. So that depends. If it's a very localized RD, then you can go ahead with the. So you're talking about prophylactic buccal. Or, that would be a broader indent, but would it actually help? I don't know, because you, again at the edge of the buccal you can get the break. So I don't. What would you say?
It really depends on how much is the area of involvement in the periphery. So if it is a small one, just area, you can sport that area, but there is no guarantee that this retinitis is not going to progress further, and then you can't keep on extending this thing. And especially in HIV positive patients, I think there is a bit of issue, because one would not want to go in with opening the conjunctiva, and there are more chances of splashes and all those things. So there are issues, and once you have a wide strip of peripheral retina which is already necrotic and scarred, I think it will not make much of difference even if you put band. Hanji Dev.
Sir, I have some query about post-fever retinitis. Sir, post-fever retinitis, have you seen cases of recurrence of CME after initial resolution of post-fever retinitis?
Recurrence of CME?
Yes, sir.
Not really, and actually we are working with Dr. From Shankar Netral, Dr. Ankush. So he also has a very large series on this. So we are trying to make a diagnostic criteria. In that we have put one of the diagnostic criteria as absence of recurrence after therapy. So it's an absolute treatment because we consider it to be sort of an infection which has gone away after treatment. So absence of recurrence is one of, we are adding it as a criteria for diagnosing post-fever retinitis.
So generally it does not occur.
Doesn't occur.
And sir, secondly, as you have said, sir, means wide rows of laser. So how do we prevent then break formation in the healthy retina if vitreous? Sometimes the vitreous gets attached to that retina, and then if we laser that area, there are chances of break formation due to that vitreous contraction over the retina, sir.
One has to ensure that we need to remove all the vitreous. So if there are multiple sheets, so you need to go till the last one, and what you can do is when you reach so-called weak aura, so what you can do is you can give circumferential relaxations
Yes.
so that it does not contract
I would
in the
also-
vitreous, not in the retina.
Yes, sir, yes, sir.
Circumferential.
I would also like to thank all my fellow speakers for contributing to this session. Thank you so much. Thank you. Okay, please, we can have a group photograph. So we were initially going only with the oral, but now again, if you say if it's a zone 1 disease close within the arcades, probably no harm. You can give one intravitreal clindamycin and simultaneously continue that. Just to be aggressive, I want the infection to go away very fast. But whether I give the second clinda or third clinda, I have rarely given more than one. Although I think PGI group, they recommend giving more than one. And again, how frequently you will give, it's a controversy because it's a toxic drug. So some people give after 72 hours, but some people say wait for 1 week at least before repeating the second. So what you can do is give one, add sulfa, most of them